Okay, good afternoon, everyone. Thank you for your patience online, as we're now going to commence slightly overtime. Apologies for that. My name is Adam English, and on behalf of the Loddon Valley Integrated Cancer Service, we call ourselves LMICS for short, who doesn't like an acronym in health. I'd like to warmly welcome you all to our 2026 LMICS Annual Forum, What is Equity to You? If I may firstly please check, particularly online, that our audio and visuals are coming through clearly. Just by way of thumbs up would be terrific, and also in the room up the back there, if someone could just give me a thumbs up, that'd be, thank you so much. Should any unforeseen tech issues present, as they sometimes can, please post in the chat, and our friendly team will put that in the background for you. For those joining me here today in the concert hall, some quick housekeeping mentions. The emergency exit is to my left here, the door that most of you would have come through today. And in the event of an emergency, please assemble on the grass area immediately outside the exit. Toilets are external to this building to my right, your left, and you are required swipe access to get in. So please, if you haven't got swipe access, please see one of our friendly team up the back there, and they'll assist you to navigate and access the toilets. Today's forum will be recorded and shared via our team as soon as possible. For those who may have registered but can't be present today, and of course, for your reference later after today. I'd like to acknowledge everyone joining us here from across our vast region, and thank you for your time to be here in your busy day. I wish to acknowledge the Dja Dja Wurrung people as the traditional custodians of the country on which we meet today. I pay my respects to elders past, present and emerging. I acknowledge all Aboriginal and Torres Strait Islander peoples joining us today. Loddon Valley Integrated Cancer Service recognised that sovereignty was never ceded, and acknowledge the enduring connection of the Dja Dja Wurrung people to country, culture and community. I'd like to extend a warm welcome to those joining us in the room, but also a shout out and thanks to our Mayor, Thomas Prince, from the City of Greater Bendigo. Thank you, Thomas, for your support in attending today. And to those that are virtually scattered well across our amazing vast region, with a special mention of appreciation to our watch party in Mildura, supported by our very own Kim Ross on the ground in Mildura. Kim's our Mildura-based project manager. 2025 marked 20 years of the Victorian Integrated Cancer Service, also known as the VICS, a Department of Health funded collective of which we at LMICS are one of 9 integrated cancer services right across Victoria, striving collaboratively and collectively for cancer service improvements and initiatives. I'd like to take this opportunity to celebrate the 20-year commemorative Aboriginal artwork behind me here, titled Healing Journeys by Vegas Fitzmaurice. The original artwork is here today in the room, and this was commissioned by the VICS, and you can also see that online here on the screen. Trust me, it's way better in the flesh here. It's an amazing piece. You'll notice early the additional to the striking earthy tones, the bay waters at the bottom, but also obviously the Murray River, which is flowing well through the Loddon Valley region, connecting us all up. Not to mention the 20 meeting places that are featured throughout the painting, one for each year, of course, of the VICS. We were most appreciative too recently to have had this artwork on loan from the VICS, but also on display in the Bendigo Cancer Centre here at Bendigo Health in the patient waiting area. And for the last few weeks, this has generated much interest and invited welcome conversation and discussion. Please feel free to take out your phones and scan online or in the room to learn more about Vegas Fitzmaurice and all the collective achievements and milestones across Victoria. My phone is ringing in my ear, which isn't very annoying. A special thank you to our lived and living experience partners. We appreciate the unique experience of people affected by cancer and recognise the invaluable contribution their insights, voices and experiences make to improving cancer care, support and outcomes. Now I've got Siri in my ear, which is can you turn my phone off? For those that don't know, I've got hearing aids and it's quite annoying. Sorry, I didn't think of that. Thank you, Siri. We'll hear directly today from Dominique on the panel here as our second presenter today, and we'll also hear from Dominique later in the panel discussion. Today's forum revolves around one deceptively simple question, and that is, what is equity to you? It's a question that sounds straightforward, but the more we explore it, the more we realise that equity means different things depending on where we stand. For a clinician, it might mean ensuring that every patient receives evidence-based care. For a nurse, it may be making sure that someone understands their treatment plan before they leave the clinic. For a consumer, equity might simply mean being able to get to treatment without travelling hundreds of kilometres or worrying about how they'll pay for flights or accommodation, take time off from work, take care of others. For an Aboriginal person, it may mean receiving care in a culturally safe environment where trust has been earned rather than assumed. For someone newly arrived in Australia, it may mean navigating an unfamiliar health system in a language they don't yet speak confidently. For someone living with disability, noting not all disabilities are visible, it may mean information that is provided in preferred print or audio formats. Now, to our agenda. As you can see here from our agenda today, we're going to hear and explore some of these diverse perspectives. And I hope we all leave recognising that equity isn't a single issue. It is the thread that runs through every part of the cancer journey. That broader perspective is reflected in today's program, as you can see, and we'll hear from Merinda about cultural safety and what equity means for First Nations peoples. We'll hear from Dominique about geography, town planning, and the design of the places in which we live. We'll hear from Julie about financial toxicity and the hidden costs that cancer imposes on individuals and families. We'll hear from Vitor about the experiences of culturally diverse and refugee communities navigating complex health systems. And last but not least, Brett, we'll hear from Brett about the opportunities for universities and health services to work in partnership and together to generate evidence that improves practice. Each of our speakers today will bring with them a different lens, but together they remind us that inequity is multidimensional. No single profession sees the whole picture. For those of you joining us online, we'd now appreciate if you could take a moment to post in the chat one challenge or barrier that you've identified in delivering equitable cancer in your region. And throughout today's forum, we'll then ask you to think about one idea or maybe one change or both that you will commit to in your own practice to make a difference. Next slide, please. We're nearing the halfway mark of the 4 Victorian Cancer Plan, 2024-2028. And this plan has placed equity, as you can see here, at the centre of cancer reform. Now, that's an important step, but you also notice the focus on 12 priority populations in the outer circle. But having equity as an aspiration is different from achieving it. This is because people don't necessarily experience cancer in equal circumstances. Where someone lives matters. Where they are near a reliable and can afford air service to Melbourne might matter. Whether they own a car, reside near a convenient, reliable public train or bus service matters. Whether English is their first language matters. Whether they trust the health system matters. These aren't peripheral issues. They're central to whether people receive timely diagnosis, complete treatment, and survive cancer. We know the Loddon Valley region is home to one of Victoria's largest Aboriginal populations, and we have a long history of diverse and multicultural communities. We know that 22% of our population is over the age of 65. 1 in 6 of us will live with disability. Over 20% experience high or very high psychological distress. And they may experience some of the most disadvantage in context of socioeconomic disadvantage. According to the Victorian Cancer Registry's latest report, Cancer in Victoria, Victorians living in regional areas are around 10% more likely to be diagnosed with cancer, and 14% are more likely to die from cancer than those in major cities. So our region includes health services doing extraordinary things, working hard despite workforce shortages, geographic isolation, increasing demand, and supporting people right across our region with increasing and more complex health needs. Next slide, please. Just very quickly, I'd like to point out the difference between equality and equity. This is a classic slide that I've seen a lot over the last few years in not only health, but in disability and aged care as well. I think the emphasis really here is 2 people beginning from very different circumstances, or 3 on the screen, but treating them identically does not necessarily result in fairness. Fairness really requires different partnerships, different investment, and different ways of working. That distinction is becoming increasingly important across health policy, not only in Victoria, but internationally too. Contemporary thinking recognises that equitable outcomes require investment that reflects geography, disadvantage, and service complexity, rather than assuming every community faces the same barrier. So what we hope to achieve today is it's not intended to be a conference where we simply identify problems. Our subtitle here is deliberate and intentional, that we shift from awareness to action. So how do we do the things differently? How do we improve or redesign services? How do we improve communication? How can we collaborate and strengthen our partnerships, to name a few? And I guess some of the issues that we often hear about transport may seem like an issue early, but it could prove to be a workforce issue encompassing. What begins as a financial hardship may ultimately become a treatment completion issue. They're not isolated issues, they're interconnected. So it's solutions that are interconnected that we need to talk about. And there's my timer. I think we focus today on what we can achieve together rather than separately and in isolation. Perhaps it's something in your own clinical practice. Perhaps it's how you partner with others. Perhaps it's an assumption you've never questioned before. If every person in this room and online leaves committed to one practical action, one change that makes cancer care more equitable for someone in our region, then today's forum will have achieved something genuinely worthwhile. I hope today's conversations challenge us, inspire us, and most importantly, help us to move from awareness to action. Thank you very much for listening. And it's now my pleasure to invite our first speaker, Merinda, to share a First Nations perspective on what equity means in regional cancer care. Thanks, Merinda.
My name is Merinda Slater. I'm foremost a Yorta Yorta woman. I acknowledge my grandmother's country first, and I identify as a Kamilaroi and Wiradjuri. Was it not loud enough? Thank you. I identify as a Kamilaroi and Wiradjuri woman from the north of New South Wales, and my mother's country is around the Cummeragunja area known as those places. I have been employed at Echuca Regional Health as the Aboriginal Health Liaison Officer for just shy of 2 years now. Previously, I have been the ALO at Mercy Hospital for Women in Melbourne. I was there for about 3 years. At my table at home, when I was maybe in my 20s, advocacy wasn't something that you did or talked about. It was something that we lived. That's my table at home at the moment, anywhere that I've been. I do acknowledge my grandmother, Elizabeth Morgan. She established Australia's first Aboriginal women's and children's refuge. My grandmother has been in about 5 different organisations I have also worked at. So I see her everywhere. My grandmother also passed at Bendigo Village in Echuca Regional Health. So it's a bit of a full circle at the moment. To me, as an ALO, some of the time, I was a very young girl when my father taught me. It will shock you. I think I was about 8 or 9 years old. Being taught how to sense when I'm not welcomed. It's tingly, you feel it. No one has to say it. Very, very young when I learned how to do that. I have experienced professionals, clinicians, other workers I work with over the years who still do it. And the problem is, as ALOs, when we sit with our patients and our clients, and we know that a clinician doesn't see that, other patients might also say something like, why do they get that? You're not seeing the barrier that we're trying to overcome. You're seeing the support we put in place to overcome it. So they're very different things. One question is, if a system has historically, any system has historically failed Aboriginal people, how can we expect them to walk through the doors and trust us? Because it's not personal, it's not you. It's unfortunately who you work for. I've called many patients that the hospital try to call, and they don't answer simply because it's coming from Echuca Regional Health. So that distrust is broken. You're going to be calling your ALO office or us to contact them, and they pick up within 2 seconds. Well, why didn't you answer someone? Well, just don't want to talk to them. Okay, that's fine. If these people are walking through the doors and already not trusting you, there's a story there that you're missing. Their grandmother will be saying that, I've heard, and this is a quote, you be careful of that hospital. And some professionals might say, that's not fair. We've never even treated that person. But that's the wrong question. That is, what can we do? You've already not walked through our doors and you don't already trust us. I have the absolute pleasure of hearing a 13-year-old girl, Koori girl, use some very colourful language about our hospital, which I won't repeat, and was very passionate. And she, insert words, hates our hospital. And she was 12, 13, turning, she was 12, turning 13. So I thought, I'm going to calm down and I'm going to help her out through this. And I said, what happened? And she goes, nothing. I was like, so you've never been a patient? No. So you've got a grade 6, year 7 girl saying that she really doesn't like us, but she's never even been a patient. She's probably born at the hospital, but she wasn't actually a patient. So I was like, well, why are you so angry? And she said, oh, well, Dad and Pop down the road don't like you, so I don't. So now imagine that, hypothetically, not that I wish it, but that young girl's going to get cancer care one day, or someone in her family, and she already doesn't trust the hospital. Because our hospital in particular, fathers weren't allowed to see their babies. Aboriginal women were separated from their babies if they were or were not forced to birth on the veranda. Said veranda has now been removed. So that's probably not just limited to Echuca. It's probably everywhere, but it is in our hospital. So, yeah, I think when I walk around my hospital and I look at my community, there's still a story there.
Thank you, Merinda. I'll now call Dominique to come forward or stay seated. Stay seated. Actually, thank you.
Hi everyone. I'm wearing two hats today. My talk is going to be, as a lived experience partner with LMICS, but also I'm a professional town planner. So I'm wearing my town planner hat for my speech today. People who are unfamiliar with town planning usually say something like, haven't all towns already been planned? Town planning or land use planning is actually not that different to health service planning. Town planning at the big picture, strategic level uses demographic data to inform decisions about how to manage a population of people. It's increases, it's decreases, and it's changes in age cohorts. In a nutshell, it organises people into activities where they live, work, go to school, access healthcare, access products and services, grow food and fibre, gather as a community, play sport, etc. It also organises how people travel between all of these activities. Populations grow and change over time, and so do their needs. So the plans for places, big or small, need to be reviewed and adapted. So yes, while all the towns have been planned, the plans need to be regularly reviewed to make them fit for purpose. I know Adam mentioned at the beginning about the Victorian cancer plan being at its 4-year mark, or its halfway mark in its plan. The process is already starting for that review, I have no doubt. So town planning is future focused, but it also needs to be reactive to changes that have been organically occurring. And in this regard, it typically has very slow reflexes. Similar to health service planning, town planning doesn't have an open checkbook. While it seeks to achieve high quality outcomes, it can't apply gold standards to everything, and very often we need to make the most of what we have. Larger population centres generally get the most attention because they can easily justify need by the weight of numbers. The key players also have bigger budgets to spend and to defend, and they drive focus their way as much as they can. It's understandable and probably logical in many ways, but it is how inequity is created and embedded into systems. And the standards set for large population centres are then imposed on smaller centres without much consideration for whether they're even achievable. But what if we did things differently? What if we started the process with the mindset of equity? What would that look like? If you look at it from a team perspective, a good team works together and works at the level and strength of its weakest team member. We've all heard the phrase, there is no I in team. The aim being to ensure that no one is left behind. Yes, the strong team members have to slow down and assist weaker members, but everyone moves together and growth ultimately occurs. If the team divides itself into the strong and the weak, the strong move at an unsustainable pace and leave the weaker behind. Individuals may achieve good things, but the team ultimately suffers. So, with that in mind, In recent years, Melbourne has been rated on various scales as one of the most livable cities in the world. It is considered to have a world-class standard of living. The 5.4 million people living in the city and suburbs have excellent access to services, education, transport, technology and activities. While preparing for this presentation, I watched the video about Rhonda's story on the LMICS webpage. For those of you who haven't seen it, Rhonda lived with her husband in Menangatang, a town with approximately 274 people in the municipality of Swan Hill. Rhonda's cancer journey included going on a trial that required her to regularly travel to and from Melbourne. And in the video, it explains that one round trip is 826 kilometres. And at the time, she'd taken that trip 37 times, the equivalent distance of 3/4 of the way around Earth. Rhonda loved her home, probably didn't want to live anywhere else. Now, I realise there's a massive difference between the populations of Melbourne and Menangatang, and there's an extreme contrast to highlight that both places are part of Team Victoria, aren't they? According to Victoria's Economic Growth Statement, Victoria is ranked #1 in Australia for total agribusiness exports, making up almost half of Victoria's total goods and exports and valued at $15 billion annually. Agribusiness takes up large areas of land, and people are still needed to operate farms, although some technological advancements have changed human resource requirements, but people are still needed. The people that run the farms have families that need access to the same basic services that people in the cities do. So why don't we start developing our plans with a team-based or equity mindset? Establishing how to provide a good standard of living for the people living in the greatest distance from services, education, transport, technology and activities, and then distribute the resources across our population centres accordingly. I'm not suggesting building a cancer centre in the Menangatang. What I am suggesting is that we start preparing or reviewing our plans with these places in mind rather than leaving them out of the process. I realise this is a radical change to the status quo, and politically it would be a hard sell because it would rearrange the long and deeply established winners and losers system that we have. But my role is to provoke you to think about how we can do things differently. And if we're serious about it, it means asking these sorts of good questions. We can all take part in processes where policy is being made and reviewed. Next time you have an opportunity to have the same plan, speak up. Thank you.
Thanks, Dominic. Our next speaker is Julie, social worker. Thank you, Julie.
I'm Julie and I'm the radiotherapy social worker in the Cancer Centre here in Bendigo Health. A lot of our referrals are for financial issues that patients are facing. In fact, it's one of the main reasons we get referred patients to social work, other than the stress around their diagnosis and health issues as well. So some of the issues we see, and I'll talk about the issues of things that come to us originally, and then I'm going to talk a little bit about some of the practical things we might put in place to help people. So Loddon Mallee, Loddon Campaspe are huge areas where our patients come from, and a lot of them are from very rural settings. We get a lot of farmers on farms who have cancer coming into the cancer centre, and one of the problems is if they're having appointments and treatment or they suddenly become unwell and the farm's their main source of income, what then happens with their farm and their livestock and things like that? We also have people who might be carers for others who might have to travel for treatment here and are not able to continue their care for their person at home. So they're having to pay for additional care to meet the care needs of their dependent person at home as well. One of the main questions we get asked is, how do I work if I'm having cancer treatment and I'm really unwell? And sometimes in our radiotherapy department, people are coming for sometimes 6 weeks of treatment and are having to stay here for the treatment. So if they've had a job, and I'm going to do a little case study in a minute about that, and they're having to take time off and they've used all their entitlements, they may have to leave their job. So really, the options for them then might be to attempt to access Centrelink. If anyone in here has ever tried to access Centrelink, you will be aware it is not a streamlined, easy approach for people, particularly people very unwell. And sometimes they think because they've got a cancer diagnosis, they're automatically able to get a disability support pension. However, Centrelink consider that a medical issue and not necessarily an ongoing disability, so that can be really hard to navigate. There's a lot of out-of-pocket costs sometimes with medical support as well. So people might come with a diagnosis and be given a treatment plan, but we all know that the best laid plans and all that can change. Their treatment can become something else, can go on longer than expected. They might need equipment they didn't expect. They might need to have some sorts of surgery like plastic surgery. That's an added expense not covered. Scans, various things. Some people also believe that private health cover is somehow superior to what we can provide in our public hospitals and end up paying extra fees that they can't afford with the thought that they're going to get the best medical care with that. Also, some people would like to access superannuation and income protection. Again, it's a difficult process similar to Centrelink where they apply for it, get knocked back, apply again and get knocked back, get doctors' letters and reports, and then it's a long, difficult process. Transport, very difficult in our region. It's clunky. So if you've got someone coming from, say, Swan Hill, up that area, they might have to get a taxi or rely on support to get to the train station. Then they've got a 2-hour trip, and from the train station, if they're getting a taxi here, it can cost up to $25 just from the train station to the hospital. We do have Pole Express bus, luckily, which can take people back, but they don't pick up. So we have people having to outlay costs. We also have our share of natural disasters in our region, and we all know about the Elmore and Rochester floods that in recent years we've experienced, as well as the fires in Harcourt, which put a lot of people on the back foot who were accessing medical care here at the hospital as well. And their priority was dealing with a roof over our head, and their medical treatment was like, we need to fix this before we come and get our treatment that we really need. Insurance is lengthy too if you're waiting on that as well. However, we have some good news because we do have things we can help people with when they're coming for their treatment if they are having some problems. So I've spoken a little bit about our voluntary express bus. So if people are staying in our patient accommodation, which luckily if they're over 100 kilometres away, they can claim on a VIPTAS or an IPTAS, which are travel reimbursement claims. So they can get their accommodation here, which is very helpful, particularly if you're having like 6 to 8 weeks of treatment and you live in Moama or you're up near Swan Hill or something like that. You're not having to and fro, so that's a cost saving for people. We have the voluntary express that will pick them up, bring them here and take them back, so that saves on parking and different things as well if they need it. If people are unable to work or they're really keen to access their superannuation and income protection, we will often refer to the Cancer Council Financial Program. So they have a team of volunteer financial counsellors who their whole world is accessing these things so they can help people get access to what they need. And that's really useful for a lot of patients. We also often refer people to local material aid emergency relief agencies as well. and they can access a utility grant scheme to kind of pay some of their bigger bills and not have to worry about that. Also, mortgages put on hold with a support letter from us as well. Different cancers have different supports, financial supports attached. So, for example, we don't have one big bucket for everybody with cancer. So you might have to access hand care if you've got esophageal cancer, or you might have to access peace of mind if you've got a brain cancer. So they're all different little pockets of money that you have to be aware of, and they can be different amounts. So it's not equitable, really, in some instances as well. And we do have the claim form for transport as well, but it's a reimbursement. So people have to upfront the cost, and then we help them apply for their reimbursement down the track. It's not the full amount, but it is a good chunk of money. And we help people by accessing certain trusts as well. So there's things like Red Cross. You might know a bit more than me about that, Vitor, but that's especially useful for people not eligible for Medicare. So that's non-residents of Australia or people on particular visas. They might not be able to get Medicare. So we need to then advocate with the hospital around costs and how we're going to navigate that. Got time for my case study or no?
I don't think we do, but we may be able to share it in our post-form wrap-up.
Yeah, no.
Thanks, Julie. Over to Vitor now. Thanks, Vitor.
Conversations as well, we'll just supplement a little bit of what we're talking about with multicultural communities. I have 2 hats at the moment as the manager of general practice engagement at Murray PH and support 208 general practices across Murray PH and catchment, which include the View, but also the London Valley region. But I'm also a member of the Multicultural Health Advisory Committee for the Victorian Department of Health as well. So we'll be talking a little bit more of my hat at the PH and next slide, please. I would like just a second, the beautiful acknowledgement of country and seeing how beautiful our own country is actually changing from that crisp winter season into our spring season as well. And you can see that changing across the flowers blossoming and the trees blossoming as well. And it's beautiful to see that changing across this beautiful country. Next slide, please. I would like to introduce you to our multicultural communities around the London Valley region in what we call the PHN as the Central Victoria Northwest. As you can see, we have a quite substantially diverse community who are living within this catchment area, particularly the populations from a Karen, Mandarin, or Italian background. And we see that changing between the Central Victoria region up to the Mildura region as well. But 2 points that I would like to bring to the attention in this slide is that the demographics of that multicultural population living within, and that's a challenge that we will address, and that's Murray Beach and that's not only London, Mali region, is that the demographic of that population is actually younger than the average age across Murray Beach and catchment, which shows that that multicultural community is actually moving to regional area because they even have a skilled immigration pathways, or maybe they are moving because they have either a refugee or an asylum seeker status. From that multicultural population, 17.5% have very, very low literacy of the English language, which is one of the social determinants of health challenges of that community accessing healthcare services overall. With the current Asian catchment, which is London, Mali, and the Hume, again, 15% of all refugee settlements actually happen here in regional Victoria. That's substantial. That's substantial, and we see that reflected across. And next slide, please. And this is a little bit of the access barriers that we are observing working in the primary healthcare sector, but also specialist care. And that's why I brought in very black hole. There is a lack of data. If you read any reports about multicultural data, cancer diagnosis, public health, and health promotion, there is always that statement saying that the data sometimes is limited. And due to a series of complexities, maybe the multicultural status of a patient is not being captured, maybe the data sets that we have are not integrated, maybe there is a fragmentation, particularly in the state Victoria government around commissioning services. So data sharing sometimes is one of the barriers that we face. When it comes to some of the challenges, I try to split into 4 main domains, and that's the first one is very linked to what you mentioned, Julie. Affordability and eligibility. Most of multicultural people, depending on their visa status, they want to have access to my Medicare. Therefore, they won't have access to most of the out-of-pocket payments that we have across Australia. And you have seen in general practices, the new book building incentive has increased a lot accessibility across regional areas, but not for multicultural communities because they don't have my Medicare status at that end. Secondly, language and communication. We have interpreter services, but the availability of those services sometimes is not on spot when you need it. And for some communities, and I would say the Karen community, which we have a higher preference and attachment, that language sometimes is not available. So how we are leveraging that communication with them. Thirdly, culture and cost and trust. Systemic racism for multicultural communities is still a thing, and they experience when accessing healthcare services. They might not feel safe because of their visa status. They might not feel safe because they don't speak fluent English, or because they might be relying on a family member to do the translation to them. And fourth, system navigation. How much of I trained myself? I'm a healthcare service provider. As you can see, I have a little bit of an accent, so I have a little bit of lived experience as a multicultural person. It took me maybe 3 years to understand the complexity of the healthcare system in Australia and the different funding streams, what sits with Commonwealth, what sits with state, what sits with community services, for example. So that complexity of healthcare services is another level of challenge as well. And that's why often we see multicultural communities accessing emergency department care instead of general practices. Maybe because they don't have an understanding that the entry point to the healthcare system are general practices. Maybe they don't have my Medicare status. Therefore, the emergency department is a free cost. And that's why they're accessing that entry point. When it comes to cancer and screening, and I will just briefly finish this because I think my time is up, is that digital engagement of multicultural communities with screening programs is quite low. And I brought the breast screening report there for breast screening. Multicultural communities in the state of Victoria have 24.5% engagement with the breast screening. And the general population, for last time that I revisited, was something I think 56 or 57. So it shows that it's half of that. And the most common cancer types in multicultural communities are different because of the social determinants of health of those communities are coming and sanitation sometimes. So you notice that the top 3 cancer conditions in Victoria often linked to infectious conditions, which is different from normal multicultural communities. Some of the opportunities then, and I just want to finalize my presentation with this, that we need to see ourselves represented in the healthcare system. And the bicultural program that we have here, which is a partnership between LMICS and Bendigo Health and other organizations, is a good example of that. And that has been praised within the cancer plan as well as a case study, because not only they can raise cultural awareness within the colleagues that they're connecting with, but also the communities can see themselves represented in that workplace. And that's a very empowering statement that from one of our participants from our health and needs assessment last year that shows a little bit about the impact of systemic racism for multicultural communities. So that's just a little bit of the message that I would like to convey today, and happy to expand on any of those points.
Thank you, Victor. Now to Brett. Thank you, Brett.
Thanks, Adam, and thanks everyone, and thank you for the invitation to come and talk today. I'm here to really talk to you about how universities and research can support one of the challenges that everyone else up here today has spoken about. And I think it's one of our real missions at the moment from a university perspective to actually engage with communities with where they're at and how health services like this one deliver personalised care. And I deliberately call that term out of personalised care because I think that's really important from what we've heard all the way through from potentially Indigenous people not feeling welcome within health services, and how we enable people to get transport to those services and get the appropriate Indigenous care and cultural care that's important for them. And it's not just about lifting up something that's being developed and is being implemented in a metropolitan city and trying it in the regions. It actually needs that partnership approach to work out how do we need to change that so that it's appropriate for various people. And it will be different even amongst this region from the people in Orangutan to here in Bendigo. And so one of our opportunities from a researcher and university perspective is to think about how do we actually get involved in that conversation? How do we become a part of your health service and engage with the patients that you're treating to improve those individual outcomes? So I think a key part there is that co-localisation. And here in Bendigo, we are very lucky in my belief to have a high quality health service and a university that is fighting that same regional mission in the same city and co-located as well. And then we can leverage out from Monash and others in this region. And so I think if we can get seats at the table and then actually start to have those conversations, that's a really good starting point. And then we can also leverage out the opportunities that the university provides around the intent planning and all those other spaces that aren't necessarily the health components, and think through, right, how can we engage different sectors to do these things that are interdisciplinary care, again, which are really important. It's not just about how do the doctors and the nurses social workers work together. But we need to think about this in the wholeness of what is our environment. And again, in the regional settings that we're based in, those regional environments change from place to place. I drive in from Seymour most days to come to work, and touching on what Vitor said about the changing environment at the moment. I see that every day, just through that very short drive, as to how that environment changes from one place to the next. And how much the creeks and the waters are flowing and what that means, which has the flow on for our health and our healthcare needs. But I think the other opportunity that engaging with universities provides is students, and it's not just the delivery of care now, it's the teaching of our future health professionals. So let's acknowledge the wrongs of the past and where we have made those missteps. And how can we actually start to provide some of those teaching and educational opportunities to try and prevent those from occurring into the future? And so I think it's really important that we actually look at this as a whole life cycle approach, where we're actually engaging our students, and student placements then become a really important thing for us to do, to give them the hands-on experience. But for them to go through that whole evaluation cycle, and the patient voices in that are really critical. All of our national funding landscapes at the moment are calling out for collaboration and end user involvement. And I can see Lee Kingston in the audience who's been really successful in getting a national grant with those consumers and partnerships engaged right here. So we've got the framework to be able to do it. And the sector that Lee's involved in is really good at doing the implementation type evaluation services. But we've also got the opportunities through the centre that I'm involved in to look at how do we best deliver and develop care, and then to develop those models of care that we then can implement and evaluate in that process. So within this environment here in Bendigo locally, we've got all those opportunities to really engage in that whole life cycle of care. And I think then the key part for us to think about how can we engage that service university partnership model to improve all of that funds is to ask all the questions which I've heard that starting today, and just to make sure that we're thinking about things in that holistic sense, and ask for who else should be at the table, so that we can really ensure that equity piece comes through and everyone gets the opportunity to improve how we work and how we service the patients so that the best health outcomes for their individual needs.
Thank you so much, Brett. Thank you. Very thought-provoking. It is now my pleasure to invite Dr. Sam Harris as LMICS co-clinical director, but also as medical oncologist here at Bendigo Health. Sam, come down, and we might give you a mic if that's okay. We got one there. I'm not going to use your microphone.
I'll stay here.
Thanks, Sam.
All right.
Thanks, Sam.
Thanks, Adam. And thanks, Adam and Merinda, and everyone else from the mix for arranging today. And I think really want to thank the speakers today for 5 fantastic presentations that I think quite eloquently summed up and covered a lot of the issues that our patients and our clinicians and our population have in getting access to cancer care in the Loddon region. I've got a few questions, and I'm pretty, a little bit sort of excited because Dominic and I have a long history, and I've answered not sure how many questions from Dominic over time. So it's nice to be able to get a little bit of revenge. Not revenge. I asked some thought-provoking questions on Dominic. But before I start, I just want to throw open the challenge to the rest of the group on stage. I'm going to ask everyone some individual questions, but none of these issues sit in isolation from themselves. They quite often overlap or cross paths in different ways. So if I'm asking someone a question and you have something that you would like to say, I'd really encourage you to grab the microphone and interrupt and start that conversation from your perspective, even though it might not have been addressed at you. But my first question for Dom and really goes back to that town planning type analysis, and I loved how you sort of compared the cancer plan to town planning, and I can see the big similarities there. One of the when we make a cancer plan, we have to reevaluate that and make sure that we're not making things worse or we're doing the right steps. When it comes to town planning, what things do you think might be happening already at a town planning level that might be inadvertently making equity harder for our patients? And that can be, broad ranging. Any thoughts about that?
It's a big question, Sam. Things that could be making equity harder, I think, as I said earlier, starting from the big centres and then leaving, you can just see the distribution of effort sort of dwindles off into nothing towards the end. I think if we could take a different approach, as I said, and start at the small end and then leave what's left for the big centres, it'll really get everyone's attention. And let's not aim for gold standard. Let's aim for a good standard of living for everybody, and think about who is producing our food and fibre and looking after everybody. Planning, like you say, in the cancer plan or the Victorian health plans and whatever, they're all guilty of doing the same things. It's all about picking up the big themes and figuring out how to make that work and how to make it as best as we can. But it applies this standard to everything that is just unachievable in small centres. Yeah. It just doesn't work that way.
And so what I hear you saying is that the plans that we have often, because they are designed at the biggest populations, have inequity built into them for people coming from smaller populations, or sometimes smaller populations that live in the big populations, right? That come from different communities inside that.
I'll give you another example. The Loddon Valley Regional Growth Plan, which is a planning document, would obviously apply across into other sectors as well. That was produced in 2014. It's still current. 12 years later. Policy cycle not working there. There is a statement in that plan that says for the Shire of Bullock, which is part of our Loddon Valley region with our smaller 8,000 square kilometre areas, that they should plan for population decline. That's all it says about Bullock.
Wow.
For Bullock.
Yeah.
How do they get funding for anything? Who is going to fund anything? Who's going to go and set up a new business? Who's going to participate in and step up into making something great happen? I can tell you it's only the people who already live there who are fighting for survival. And that's not good enough.
Unless they're being asked, unless they're part of the planning process themselves, that they're never going to get addressed.
And when you've got a dwindling population base that's also ageing, and he's also exhausted from being the same volunteers on all of the same things. They just don't have time. They're also running their own businesses. How do they do it? Well, we have to step up and help them, I think.
Absolutely. The rest, panel, any comments on this theme or topic?
Thinking about over planning, I think we were having a conversation before the session as well.
Hold it down, this one. Oh, down.
Now,
Yeah.
no.
I don't even think you need it, to be honest, because it's annoying. Apparently, they can't hear you online.
Oh, can you hear me now?
So the
Is it better?
online's there. So just, I'll take.
That's fine.
Yeah.
So I think we were discussing, I think urban planning has such an important role in health promotion most of the time. And then if we are engaging communities to be more active in their exercising, but that's not reflecting into urban planning, there is not, I think, continuation in that regard. And for multicultural communities in particular, you might have a beautiful urban planning, but if that community is not safe for them, they might not engage in that sort of social interaction or engaging in any other activities because they maybe not see themselves reflected in the community, or maybe they don't feel safe or engaged. So I think there's always that intertwined relation between them as well.
Absolutely. Merinda, I loved hearing you talk. I love that phrase that in your house and your life, advocacy is live, not talk. And you can see that in any interaction that we have. And the other thing that I took away, two things I took away from what you said that really struck home to me was one, that clinicians they don't see the barrier. So they see the barrier, they don't see the work that's been done to overcome that barrier. And I thought that was really powerful. And then the other thing that you brought up was the impact of intergenerational trauma that causes, that still resounds today and causes difficulty for Aboriginal patients to trust centres like Echuca or Bendigo Health. I'd love if you could just expand a little bit about any of those, either of those three topics, perhaps the intergenerational trauma and how we might recognise that as clinicians and ways that we might start addressing that, I guess.
Yeah. First of all, we never assume anything really. And I think I have met some clinicians and professionals who love to assume.
Sure, yeah.
I mean, I think about myself and sometimes I think I grew up quite privileged still. And then I also think about hearing, it's terrible what happened 200 years ago.
Yeah.
Yes, and unfortunately, it doesn't erase. I mean, my mother tells me stories of growing up in St. Albans, and her and her sisters are getting stoned walking to high school. I'm 60,
Yeah.
not that long ago. So that's a story.
Yeah,
that's just something that I carry.
Yeah.
Everywhere with me, and like I said, history doesn't erase itself; it carries on. So we hear those things like someone has said, I told her to be careful, it wasn't our hospital. I told her to be careful of that hospital. And that could mean a million different things to that family.
Yeah.
So when I think about the young girl who said she hates us, cool.
Yeah.
Whereas other people are saying, well, that's not fair. Yes, but you would know, when I think about a patient or a client, and if we know them well, we know, or I think about what they're going home to, what their home is like. I could then spit off some family members of someone, and I've heard clinicians go, it's quite for use, it's quite textbook, what you've learned in university or something like that. But for us, it's what we live.
Yeah.
So I think about what they're going home to. I think about who their grandparents were. I think about what that time of living was like. I grew up with stories hearing about what happened, for example, Kevin Coombs, that's what I grew up with, distrusting hospitals because there's no one in Melbourne, I don't think. Stuff like that makes some Aboriginal patients distrust.
Yeah.
And that's not, like I said, not personal. Something else is, and it's just come up yesterday, an obstetrician said, I'm really interested in some of the traditional medicines. And I said to her, you don't have to automatically agree with that patient, and you don't even automatically have to do it. Old man weed grows traditionally in this area. It's great for dermatitis, great other things, but just allow your patient to talk about it. Cancer Council came up with something that gumby plant is really beneficial. Even if there's no science behind it, giving that person the belief that you're giving them a chance, otherwise they're going to shut down and you're going to miss something really, really, really important.
It's that recognition, isn't it? And that everyone has a different way of seeing the world. Everyone has a different understanding of how the world works, and no one way is correct, right? And it's being able to live in a place where we can have different understandings, but how can we work with them best together? And just because I may not think the same way you do doesn't mean what you're saying is anything less valuable.
Correct. They can both be valuable at the exact same time.
Thank you. Vitor, I'd be keen to hear from you because trust came up in your top topic as well, and I think there's a lot that's in common there. And I wonder if that there's the multi-generational trauma, because often patients coming from overseas will have escaped, areas that were in conflict or war, and would have come either directly affected by those conflicts or having heard stories from the parents or grandparents about that. And how does that affect, do you see the parallels of what Merinda was saying today?
Yeah, intergenerational trauma among multicultural communities, particularly refugees and asylum seekers, more prevalent, particularly because they might have come from war zones or maybe any dispossession in the country of origin as well. And even the whole process of being included into a new society through a visa process. Sometimes there might be some litigation or legal process involving this whole resettlement. It definitely brings some challenges of them in their experience when they're moving to a new country. Particularly in regional areas, that could be, there's, I think, another level of complexity because they might find people from the same multicultural community of themselves, and they are able to establish those social networks of support in which they can provide their own self-experience with that. But they might come from communities in which there is no one else like them in that particular aspect, and just make them to feel in a very unprivileged opportunity within the society that they are living. And that's, I think, is only one aspect across those multicultural communities. When it comes to accessing care, particular healthcare, and we know how diverse multicultural communities is, the perception of even, and I think we are in a cancer forum, talking about the word cancer may bring a lot of stigmatization within the communities that they're coming from. So that's why most of the time they might delay seeking care for that particular condition because being fearful of being stigmatized within their local community, but also within themselves. And even when a provider approach them saying the word cancer, maybe that rapport and trust might be lost from that standing point.
Yeah.
And that's the benefit of having a bicultural sort of model in which those people can provide the cultural guidance for the provider as well.
Yeah. Couldn't agree more. We are slightly running out of time, but I'm an oncologist and I'm always running late. So let's keep going. Julie, I'd be keen to hear from you. What do you think you spoke pretty well about a lot of the different financial toxicities or costs there are for our patients and their families. Is there one or two that you think is probably the most overlooked or the silent costs for patients and their families that, okay, everyone knows that travel is going to cost, so we're going to get tax and get that. But are there other costs that don't get recognised as well that come up in your day to day?
Yeah, I think definitely it's not a monetary value as such necessarily, but the cost to people's mental health because of their financial hardship created by additional costs with their healthcare is one that definitely we see a lot of. And we might get a referral for somebody because of distress, and they might be saying they don't want to come. A common one might be, we're worried about the patient, they're saying they don't want to come and have their treatment, with the assumption that it's all about, they just don't want to have the treatment and they're scared of chemo or whatever. But often it results in us understanding more when we're talking to them about it's that they don't want to actually come because they've got financial responsibilities for their family. They need to try and keep working. They're scared about accessing their superannuation, for example, because if they access it now, what then will that mean for their family down the track? That they'll be leaving them without something that everyone's sort of thinking they're going to be having access to. So I think that financial hardship can cause a range of ripple-on effects, but one of the main ones is definitely anxiety around coming to treatment and what that might look like, and will the treatment cause them then not to be able to work anymore? That sort of thing is a big one. I think too, sometimes one of the things we'll see is people wanting to try different things. So they're understanding that their treatment might be long and difficult. So sometimes they'll pay exorbitant amounts of money at times for an alternative therapy, for example, because they're wanting to give themselves the best outcome they possibly can. Or someone said, don't have sugar because it's going to feed cancer, just go and see this naturopath. And no dissing naturopaths, I'm all for natural things myself, but occasionally it's, and if they're swapping that out for their medical support as well, they can be paying a lot of money for a poor result. And we know that financial hardship creates bigger problems for people with their health. Because if they can't afford to look after themselves well in the first place, then there's a roll-on effect with how they're able to get through their cancer treatment and survive, really.
I think that's so important. That sort of echoes a bit what Merinda was saying as well. And I think the important thing as clinicians and that working is not to say, oh, don't do that natural therapy. It's understanding what's behind that decision to do that and how can we incorporate that into what the treatment that we're doing as well. Brett, final question for you. I'm keen, I'm an oncologist, but also involved in research and keen to promote as much research, particularly in Bendigo. And I think a large part of what equity means to me is getting our patients in our community involved in research close to home. Having heard the presentations today, what sort of opportunities do you see for research in the future, looking to try and improve equity, or just research that can get our community involved more?
I think there's lots of opportunities to do that, and feeding through the last couple of responses to your questions is all of our systems, and particularly our research, has been driven around single conditions. We've got lots of evidence to know that this works in this cancer, or this works in this cancer, but we actually haven't started to integrate all of the other components of health that go with that. And so this whole concept of multi-morbidity, within Australia, 38% of all adults have more than one chronic condition. When we get into the regional areas which we're in, that goes up to 56%. And so it's not just about dealing with cancer in this instance. It's about all those other things, and the mental health becomes a really key component of that. And so I think our opportunity is to engage with what's really important for the patients and the health services to think through, not just what's good for your cancer, but what's good for you. And then we can start to dive into that research and generating that evidence for that spectrum of conditions and multi-morbidity, rather than just focusing on the single condition.
And that's so important, because so often we see clinical trials that have very, very narrow, you have to be Superman. That Superman problem didn't get into the trial, not a problem. Not a problem, but really hard to get into. We're opening up our research to include more of the everyday person, if I can use that term, that's going to provide research that's more valuable for the community and more generalisable to the community.
And I think that's the option we've got in the regions, because we do have more of those generalisable people and fewer of those really specific, narrow people. I know that in the clinical trials here, the recruitment rates are low because there's so few of those people with those strict criteria coming through. So that gives our opportunity to engage with people in research and generate that real interest.
It would be really good, sorry to interrupt, but talking about clinical trials, that some sort of financial support came with them, because we have a lot of people from our region who have to go to Melbourne for their clinical trials. And I had a call from a lady last week saying, you know, is there any financial support you can find for me, because I'm having to come to Melbourne regularly and it's costing me quite a lot with accommodation and different.
I will say there has been a recent change in the system now. It's has a program which never used to be able to be used for clinical research, now can be used for research. That has made a difference for our trial participants. Some studies will sort of other time. Now I'm getting some death stares from here. So, not at all. Look, I just want to, can everyone join me in a round of applause? Is this Melissa, or we need to go? Yes. Oh, yes, yeah. We do have extra time. Are there any questions from online? None. All right, do we have any questions from the room? Yes. Yeah. No questions from the room? Yes. Come down. Oh,
good afternoon, and thanks ever so much. Really interesting talks from everyone, and I'm really interested in, you've mentioned clinical trials a lot, and especially Julian mentioning that some patients go out of their way to spend lots of money to try alternative therapies. And I know clinical trials take a lot of planning. There's so much money involved in setting them up, and that's why we have mostly them in Melbourne. But I wanted to find out if there's sort of a pathway for our patients in the region where they could sort of access this through sort of a special, the SAS, the special access schemes, and how many of our patients, you probably would know more about that, would be able to have that here.
Thank you. I can probably answer that question unless anyone has got. Getting access to clinical trials is an issue. Getting access to new medications can come by the PBS. One of the big inequities in our system is that there's always a period of time between when we know a drug can be effective and when we know it, when it's available for the population. And there sometimes are special access programs where that drug can be accessed, and that is, we can do that as well from Bendigo as from Melbourne, but more often than not, that comes at a cost, and that those costs, unfortunately, for cancer therapies in today's age, is running into the multi-thousands of dollars, and it's just not affordable for the majority of our patients. So it's a big issue that we face. Any other questions for the room, or any questions from the panel? Talk to that. Yes. You can just yell or talk about it.
Merinda, and I heard a little bit about the intergenerational trauma. Merinda, I'd just like to probably ask you, what are we doing in our hospital with our children? Because that story's been told from the old people. That's getting passed into our children today, and it's still happening. What are we doing in the hospital for our children so they can know that the stories are important, that our children need to move on from the stories to actually have their own views of what a hospital is about healing?
Well, I think you and I were both very exhausted the last couple of years after running, I think, a program that has, I can confidently say, not been done in any other health service. Stemming from the young girl swearing in my car, We decided to run an event and we called it the Walk on Country event, where, you know, the dream is to invite all schools in the Echuca area. But that's a bit of a pipe dream because we can't do that. So we invited, last year was its pilot, Koori students from grade 3 to 6 from 2 local primary schools to come through the hospital. And it stemmed from the stories that are being passed down, even though they've never even stepped foot. I mean, this kid has never even looked in our hospital, even though she asked, does it count that I was born? No. Yes, but no. So hearing stories from another child saying, my nan said he's a racist. I was like, oh, I do know that to be true because I actually got your grandmother's complaint. And he goes, yeah, but I know you're not though. And I was like, how do you know that? Oh, because of what we did last year. So that same school attended again this year. We added a 3rd school. So we had 3 days of showing the local Aboriginal children that they do belong. And we have some beautiful people. We have artwork. We have a space. We have a space for you to contribute safely as well. We have our Mulka room. Mulka is a Yorta word meaning shield. So that's our room. And we got them to paint something so simple is painting on rocks and then leaving them in the courtyard so that they can come back and look at it. And I kid you not, probably every kid drew an Aboriginal flag. I told them they didn't have to. I said, do anything you want. And almost every single one of them did an Aboriginal flag. So they're all coming up to us, showing us, and they all look the same. That's them. That is what they wanted to know. They're walking around going, they're seeing nurses at Big W saying, do you know Auntie Merinda and Uncle Gilbert? And then that staff member is coming into our office and saying, some kid from this primary school asked me about this. I'm sorry, she hasn't even met us. And it's catchy. So we've got schools begging to be invited next year because we're showing them that they belong and that those stories can still be true because they are, but we're trying to change.
That's an amazing story, and I hope you're sharing that loud and wide and a bit more hearing because, you know, there's so much, you hear so much talk and there are so many millions of dollars being spent trying to address big problems with inequity. A simple program like that, and actually herding 3 schools through a hospital, not simple at all.
85 Koori students.
Yes. But something, an idea as simple as that will have everlasting, you know, benefits, and those kids are going to, and their families are going to reap those benefits.
Yeah. And well, we're also kind of hoping it might be a bit of a employment. You know, we threw in the questions: who wants to be a nurse?
Yeah.
Who wants to be a midwife? And no one put their hand up. Okay, that's all right.
Can I just add to that? I think what you're talking about is trust, right?
Yeah.
Yes.
And one of the things, particularly from a research perspective, one of the things that we don't do well, and I think we can do better, is communicate back the findings of our projects. And even from a health service perspective, we all fill in surveys and everything on our experiences here. We turn back up, and what do we see change? Sometimes it's nothing.
Yeah.
And I think it's just about how do we communicate what we're doing, and sometimes we can't do anything, but we need to be able to communicate. We heard you, and we're working on a longer term solution to build that trust. And I think that's a key thing that we can get through all the way through.
It's a critical last link in that research cycle is feeding that back to the people that the research was for in the first place, to show them what their research meant and how that's changed what we do.
What I also take from you, Merinda, and your story is that the individual matters. And if we start at that level and work upwards instead of starting at the big institutional structural stuff, we're going to have a better chance of getting it right, aren't we?
Yeah.
But you can think that you are. I think you can think you're getting it right. And then also the community don't believe that's true, but they can also exist at the same time.
Exactly.
Yeah, they can both exist. There's room for both.
But what you're doing is going a long way to ultimately, when those kids are, adults and those kids are leaders, the trust is going to be better. It may not be 100%, but it's going to be better than it is at the moment.
Yeah, okay, we'll get it there.
Yeah. Look, that was amazing. Thank you once again to our panelists. I'm now really excited to invite Minister Laura to the stage, who's the head of the integrated cancer. Well, no, what's your role? She does everything.
Thank you very much. I don't want to take your role there, Adam. I'm Mel Laura. I'm the development manager at the Cancer Centre. I'm really heartened to hear all these stories today because part of my portfolio is around regional cancer service planning. And so to hear around equity and to hear this think tank kind of idea, it's a really nice segue into something I wanted to share with you today. So I guess I firstly wanted to acknowledge we're all meeting on Yorta Yorta Country, and I want to pay my respects to the custodians, but also the incredible sharing of knowledge that you bring today, both here and across the region, that we're seeing and that we're learning from those insights. So thank you. But yes, I'm pleased to just share some details in a few short moments around a new Aboriginal-led initiative that Bendigo Health are going to deliver in partnership with the Bendigo District Aboriginal Cooperative, together with community across the region and other health service partners. So this initiative is funded by federal funding. We've just received this. It's from Cancer Australia Partnerships for Culturally Safe Cancer Grants Program. So to the order of 700,000 over 2 years. The project has been developed to address persistent inequities, particularly in our region that we've identified for Aboriginal and Torres Strait Islander people, around cancer care and outcomes. So we know in regional communities these challenges and barriers are exacerbated, and this is an opportunity to collaborate, to work together. So at the core of this project, it's really about improving experiences of cancer for Aboriginal community through embedding Aboriginal leadership from the start, developing strong relationships with our partners, particularly mainstream and ACHOs and all of the other partners that come together in that space. And we'll be co-designing a model of culturally safe cancer care for the region. So that's our approach is going to really ensure Aboriginal voices are at the forefront and they're leading the design process. We'd like to implement a place-based approach, which is informed by our community. And I have to say, a lot of work has gone in the background, about 12 months of planning between different services, building relationships, identifying some needs or some common threads and things that would get us here. So we weren't successful in first round, but we are on this second one. So what are we going to do? Well, the project has two key components. One of them is around establishing an Aboriginal cancer navigator role that will be co-designed and led by community. It will act as an interface between hospital and community care to support and provide some of that vital navigation, linking in with our Aboriginal Health Liaison Officers and other components around that. But essentially, enabling culturally safe cancer care and responsive cancer care. The second component is the creation of an Aboriginal-led peer support network. This is going to be led by Karavina and some Indigenous consultants that are coming in to work with us around this space. So this will be a network which will bring together people living with cancer, survivors and carers and more, feeling culturally in a culturally safe place to share experiences, get social connection, and the ability to maintain some quality of life beyond, which previously I don't think we've done very well, and we're still, so there's a lot of work to do in this space. But the project is not just about introducing roles and services, it's bigger. We're hoping that this will bring systemic and transformational change with key focuses around cultural awareness, building capability of workforce and services, so that we are better equipped to provide culturally safe, trauma-informed care, which is around Aboriginal healing kind of concepts, and we're still to learn so much in that space. So our goal is to create an environment where Aboriginal people, where they're treated here in Bendigo, they're moving in and out of different services across the region, can feel, sorry, I've lost my place, have improved access to care, a reduced isolation, and really, I think it's about building that trust and ensuring those experiences are improved. So we want Aboriginal people to feel confident in engaging with cancer services, and that's going to take time. We want them to be involved in making informed choices about their care in their community and close to home. Well, another element of this will be a fairly heavy evaluation process, which will be using Aboriginal methods, will involve Latrobe, Violet Mines Marshman in that space. And that will be around working closely with partners and community through different learning methods, gathering insights, reflecting and modifying the way we do things. So I think, just to conclude, I'll probably have reached my time. Okay. This project represents a really important opportunity to work differently, to collaborate and to walk with mob on the journey. So by combining Aboriginal leadership, navigation support, peer connection, and uplifting that workforce capability and the awareness and growing and relearning or unlearning sort of the ways of doing, we hope to create a meaningful and lasting improvement in cancer care for Aboriginal people across the region, with the ability to adapt across our other regional areas. So we're super excited to begin the journey. We've got a lot of, I see faces in this room who are already part of the involvement, but we'll be really engaging more community. We'll be inviting others to be involved, to support us, to have this really Aboriginal led in terms of the way we do it. So we're kicking off in July, which has passed. We are in the planning initiation stages now, and looking forward to sharing our learnings along the way through mechanisms like LMICS and other parts. But thank you.
Thanks very much, Mel. And again, thank you to everybody on the panel today. Very thought-provoking. We did ask at the start that we leave this room with a commitment to each other that, you know, one change, one idea, one concept that you'll commit to in working with us and working together towards making a difference in equity. We also asked our online participants who have been very patient as we've gone well over. Thank you for your time, but we also seek your input through the chat there, so you can drop some thoughts in there. And in the room, we'll post our thoughts on the post at the rear to take forward. So a sincere thank you to Dominique, Merinda, Julie, Vitor and Brett, and to Dr. Sam Harris for his time today and enthusiastic panel discussion. So in closing, thank you so much for your attention and attendance, and we look forward to working with you soon. Thank you.